Hello everybody and welcome to this week's episode about reading your slides. The objectives of this session are in part to help you gain time, which is important in practice, and to improve your diagnostic potential. Not only to help you increase the number of samples in which you will be able to make a diagnosis, but also to help you make a more confident, specific diagnosis by reading your slides in more detail. And also to help you avoid missing lesions, because as you know, that whilst looking for a primary lesion is important, it is equally important not to miss any secondary lesions that may be present. For example, it's not just because you see bacteria within a neutrophil, which indicates infection, that you shouldn't look for an underlying tumour that may also be present. The best thing is to examine your slide as soon as it comes out of the stain. It will already provide you with information. The first question: is it dry? The second: does it seem to have material on it? And then, what macroscopic colour is the material on the slide? Here you can see a slide which seems to be devoid of material, which is the case. Here you see a slide that is rich in material and very blue in colour. Cytologists often say that the colour blue is associated with the presence of lymphocytes. It's not always true, but it's worth keeping in mind. This slide is dense, and it is possible that the cell detail may not be visible. This one here will possibly provide the best information, because you can see that the material is well smeared across the slide. The cell detail should be visible. These slides show material that is green tinged and likely contains blood. Although these slides seem rich in material, it is possible they won't contain any cells of interest. If we look at this slide here, it is from a bone marrow aspirate. You can see the material that is purple tinged, which is most likely blood, and here there are several islands of material which are darker in colour, and which most likely contain the cells of interest, and are the spicules of bone marrow. The second step is to look at the slide systematically under the 10 times magnification. To do this, you start in one corner of the slide, and then, in a systematic fashion, you will go backwards and forwards through the slide in a manner that prevents you missing any part of it. What should you have in mind when you're scanning through your slide? The first thing is to evaluate your stain. If you find it is inadequate, you can restain it. Then you will look at the background of your slide. This is vital. Is there any contamination? For example, in a bronchoalveolar lavage, you need to examine the slide and identify any contamination from the pharynx. Because if you have contamination by the physiological bacteria present in the pharynx, your bacteriology sample will be falsified. So knowing this from the cytology is important. Then you need to see if there's any hemodilution. There is nearly always some present. It is important to evaluate the proportion of blood contamination when you are counting neutrophils. If you see a large number of neutrophils, you need to ask yourself whether they could simply originate from the blood before you make a diagnosis of inflammation. This is the most important part of evaluating your slides for hemodilution. The next question you should ask yourself is whether there is any sign of necrosis. Even if it is not a primary reason for performing the cytology, it is an important element, as the presence of necrosis will stimulate inflammation. So identifying it is essential. Next, are there any naked or bare nuclei, those that are devoid of cytoplasm? It is important to be aware of their presence and not to confuse them with intact cells. A nucleus devoid of cytoplasm tends to swell, and therefore you risk to overestimate the size of the nucleus and that of the nucleoli as well. In addition, the presence of naked or bare nuclei can provide information. If they are destroyed, it may indicate rough slide preparation, and resampling may be necessary. However, if they are present on a carefully prepared slide within rafts of cytoplasm, it may be a nature of the cells themselves that they are particularly fragile. Tumour cells are more fragile than normal cells. This is especially true in lymphoma and neuroendocrine tumours. It is even how we identify some neuroendocrine tumours, by finding naked nuclei surrounded by a raft of cytoplasm. What are the neuroendocrine tumours? Well, for example, insulinoma, thyroid tumours, and pheochromocytoma. Returning to the background. Is there a presence of a non-cellular matrix on the slide? It is important for you to identify the origin of the cells. For example, is there a blue lake, which is compatible with saliva, or a pink homogeneous material compatible with cartilage or bone, or a fibrous material, which can indicate collagen, and can orientate your diagnostic towards a mesenchymal origin? Is there any mineralization? All this is important to note, even though technically speaking, it is not associated with the cells themselves. Are there any granules? For example, in identifying a mast cell tumour or a melanoma. These are the questions you should have in mind when making your first overview of the slide. Is there any contamination, hemodilution, necrosis, bare nuclei, matrix, or granules? It is also important to verify that you have intact cells. You will need to see if the cells are organised, and in what manner, which can give you an idea of their origin. You need to see how many cell populations are present. Do you have one single population or several? Is there inflammation present? Are the cells epithelial or mesenchymal? All this is important to note. Once you have looked at the overview of this slide, you will pass on to the really interesting part, which is the cytomorphological details. These you need to examine at 40 and 100 times magnification. At these magnifications, you should only examine intact cells. Your first question should be, is there inflammation? If yes, what type? What cell type is predominant? Is it macrophages, neutrophils, eosinophils? Are there infectious agents present? Are there bacteria within neutrophils? Or in the case of macrophages, is there any sign of associated fungal infection? Are there any other non-inflammatory cells present? If so, what cells? Are they round cells, mesenchymal cells, or epithelial cells? And if so, do they show any criteria of malignancy? This is the process to follow. So I propose that we apply all that to a clinical case. So Sheepy, a female neutered dog that presented for hematuria and dysuria. I will show you a slide of a urine sediment exam of a free catch urine sample. So the first thing is to place yourself in the corner of the slide. I scan through the whole slide at a moderate speed. It can take less than a minute to examine the slide completely. So you can see in this first part of the slide there is not a lot of material. We continue scrolling through. We start to arrive at material here. What we can see is essentially blood. But then little by little, as we scroll through the slide, we can start to see areas that are more blue and are probably cellular. We will look at them in more detail. So you can see the principle behind the process. I won't scan the entire slide with you now, but you can see the idea of what you're trying to achieve. Once you have an overview of the slide and you have identified regions of interest, you will examine the cells on a higher magnification. Here you can see polyhedral cells, which have a clearly defined cell border. This allows us to identify them as epithelial cells. Our first objective is complete. In order to examine lots of cells, you will need to constantly switch from weak to strong magnification. So now we are looking for a raft of cells, which once identified we can look at in more detail and look for important information. Most importantly, we're looking for criteria of malignancy. Here there is a big cluster of cells close together. These cells have a high nuclear to cytoplasmic ratio. The nucleus takes up a lot of space within the cells. We start to see more cell detail, anisocytosis, difference in cell size, anisokaryosis, difference in the size of the nuclei. The cytoplasm is hyperbasophilic, and sometimes the nucleolus is prominent. What you can see here is another area of multinucleation. To the right, the presence of anisokaryosis within a cell, which has an odd number of nuclei, and in the centre, a cell in unsynchronized mitosis. We change the field of view again, and what is interesting in this cell is that they have vacuoles with a pink granular contents, classical for transitional cells, which you will remember from the very first presentation in this series of the prostatic carcinoma. So, thanks to an ordered approach, we have been able to diagnose Sheepy with the transitional cell carcinoma of the bladder or urethra. However, it is important to remember that not all transitional cell carcinomas seed into the urine, and you can miss the diagnosis if you rely on urinalysis alone. But if you see cells with as many atypical features as this, in such a large quantity, in the absence of inflammation, there is a very high chance that there is a transitional cell carcinoma. So that's all for today. See you back next week for another session on identifying cell types. See you then. Goodbye.